Okay, ready to go. I want to welcome everybody for joining us for this presentation on drug addiction and pregnancy. This is our fourth program in a series of 6. Our presenter today will be Dr. Erica Schipper. Dr. Schipper went to medical school at USD and completed her residency in the Navy at Walter Reed and Bethesda Navy Hospitals. Dr. Schipper also did a fellowship after her military service at Palo Alto in minimal invasive gynecologic surgery. She currently practices OBGYN here in Sioux Falls, and she's a clinical professor with the University of South Dakota School of Medicine. And lastly, I want to mention that Dr. Schipper is also the vice chair of the South Dakota section on the American College of OBGYNs. And so, Dr. Schipper, with that, I'll turn it over to you.
Thank you, Mark. I appreciate it. For the delay getting started, everyone, it seems we had a little bit of technical difficulty. If you can hear me, please tell Mark or I don't know exactly how all this works, but make sure you somehow let people know that I can't be heard. But I think we're okay now. So as Mark said, today I'm going to be talking about drug addiction in pregnancy, and I'll be focusing more on opioids, but we'll talk about a few other drugs as well. Let's see. There we go. I have no conflict of interest or financial disclosures to share. These are our objectives. And, basically, the important thing here is that we recognize who to screen, when to screen, and how to manage when we find that our patients have a drug problem, particularly in pregnancy. It's a prime time for intervention and have lifelong effects because patients tend to be motivated to improve. So we're going to talk about signs and symptoms, as well as the effects of drug use in pregnancy and pregnancy on drug use. And again, I'm going to focus mainly on opioid addiction because that was kind of the SDSM focus of this series, and I think it's obviously very timely and pertinent. We talk about management of opioid dependence and in pregnancy, as well as general pain management in pregnancy. And then we'll talk about some resources for support of mom and baby, both during and after pregnancy. We'll briefly touch on some social and legal issues, and then talk about some other substances as well. So this is the problem. Some of this is going to be redundant from previous webinars, and so I'm not going to get into too much detail. All of you probably know this. But opioid use and opioid use disorder in pregnancy have increased along with the national opioid epidemic. And in 2007, 23% of Medicaid patients filled an opioid prescription in pregnancy, which is a pretty high percentage when you think about it. We have seen a 5-fold increase in prenatal opioid use in 10 years up until 2009 when the data came out. And neonatal abstinence syndrome, which was previously known as neonatal withdrawal, has increased from 1.5 per 1,000 to 6,000 births from 2013 with large costs in related hospital charges. And we've realized that substance use, in particular opioid use, is a major risk factor in maternal deaths. And as you have all heard in the media, the United States has an unusually high maternal mortality rate for a first world country. Opioid use disorder was replaced in the DSM-5, or replaced opioid abuse in the DSM-5. And criteria includes 11 symptoms with severity defined by how many symptoms are present. It's important when you see a patient who is using opioids to differentiate between, is it medically indicated? Are they misusing opioids for recommendation? Or is it really an untreated opioid use disorder? Do they have a dependence on these drugs? And this does occur across all races and all socioeconomic strata. So this is a new DSM-5 diagnostic criteria. Again, I'm not going to go through this. I'm sure it's been covered in previous webinars, and there are certainly people who are better experts in it than I am. But screening in pregnancy should be done at the very first prenatal visit and should be universal. As mentioned before, it spans all racial, ethnic, and socioeconomic groups. So screening based on perceived risk factors will definitely miss cases and will contribute to inaccurate stereotyping and stigma, and possibly preventing people from seeking care. I also advise make it very clear that you ask all of your pregnant patients the same questions. If you explain that at the outset, then your patient will not feel like she is being singled out, and I think that's really important. It's ideal if your patient is alone. I realize that's not always possible, but if you can find an excuse to get the spouse, parent, whoever out of the room, that's the best time to do it. Oh, sorry. Let's see. And of course, providers should protect patient autonomy, confidentiality, integrity of your relationship. Know your state's laws regarding disclosure of substance use disorder, and we'll talk about that a little bit later. Screening, of course, I think you're all probably familiar with the SBIRT, which is screening, brief intervention, and referral to treatment. It's always important as providers to remember that we are not a one-month show, and we're not expected to diagnose and treat everything in a vacuum. There are resources out there to help us, and I'm hoping I'm going to be able to share some of those with you today. That last bullet point is some screen options. The 4 Ps we'll talk about, the NIDA Quick Screen, CRAFT Substance Abuse Screen. That's for adolescents and young adults, and it really is a good one. That's easy to find online, and I'll give you the website for that later. So Ps. I kind of like this one because it's just easy to remember and it's quick. So the first thing is, do parents have problems with alcohol or drugs? And does your partner have problems with alcohol or drugs? Have you in the past had problems because of alcohol, drugs, and include, of course, prescription medications? And then the present. So how about in the last month? Have you been drinking alcohol or using any drugs? Obviously, any woman who admits to any alcohol use in pregnancy does need to be counseled at. So this to be just a quick and simple assessment. Again, like I said, always make it clear. These are questions that I ask every pregnant patient at their first prenatal visit. This is a question for the NIDA Quick Screen, and then if they respond in the affirmative on these, it goes on there. And again, I'll give you the link to that as well. I think some of you probably do use this. Let's see. My phone behaving. Urine screening. So urine drug screening is really not an ideal way to screen a patient for reasons. First of all, really do need the patient's consent, and it needs to be done in compliance with state laws. To inform the patient of any potential ramifications of a positive test, meaning do you have to report it? And in South Dakota, you do, depending on the circumstances, and usually in pregnancy, you do have to report it. Know the limitations of urine drug screening. A positive result is not a diagnostic of an opioid use disorder. Negative test doesn't exclude occasional use of opioids. It obviously may not detect synthetic opioids. Sometimes it misses some benzodiazepines and certain designer drugs. Another thing, too, is false positive tests can occur, and the legal consequences for that patient can be devastating. They can be mired down in months or years of litigation and court proceedings, and, of course, great expense and stress. So it's important that you know your lab test and request confirmatory testing if you that it is indicated. So consent is required for a maternal urine drug screen. We most often end up doing these on labor and delivery. Does not specify whether verbal or written consent is necessary, but obviously written definitely gives you a better portrayal in terms of yourself. The patient is unable to consent because they are severely under the influence or they're unconscious or for whatever reason. The South Dakota law does allow for others to consent, and the on the slide is the order in which they can use to the next person, I guess, down on the list. So let's skip up to managing pain in pregnancy. Who is pregnant who presents to you with pain? Obviously, and most of you all know this, but it is important to remind ourselves before prescribe opioids, ensure that they are indicated. Maximize your non-opioid therapy, and sometimes we forget some of those other things like physical therapy, exercise, behavioral, chiropractic, and then of course non-opioid medications. Discuss with your patient the risks and benefits of using opioids, including the risk of physiologic dependence, risk of neonatal abstinence syndrome, and of course take a thorough history of their substance use and review the prescription drug monitoring program. For women who are not pregnant but need pain relief, do discuss their family planning and the effects on pregnancy, and if they're not on contraception, would be certainly something to consider. If opioid therapy is indicated, go ahead and prescribe it. If she needs it, then she needs it. Don't withhold it on the basis of, for instance, a risk of neonatal abstinence syndrome alone. Heroin, because we are seeing a huge rise in this with along the opioid epidemic. Heroin is obviously associated with a lack of prenatal care, and that causes heroin itself, but also mainly the lack of prenatal care causes an increased risk of fetal growth restriction, placenta abruption, fetal death, premature labor, and meconium. Of course, it's associated with high-risk activities, including prostitution, trading for drugs, and then other criminal activities, with higher exposure to sexually transmitted infection, domestic and other violence, and then, of course, there are legal consequences such as loss of child custody, criminal procedures, proceeding incarceration. A woman who is opioid dependent who can over and get that medication in pregnancy is more likely to turn to heroin, and the consequences then become much more dire for both the mother and the fetus. For a patient who is dependent in pregnancy, like I said at the beginning, pregnancy is a great opportunity for patients to control their dependence. They're usually very motivated to improve their health. For opioid use disorder in pregnancy, therapy is recommended with methadone or buprenorphine. Medically supervised withdrawal is actually not recommended and is associated with high rates of relapse and poor outcomes. So opioid therapy with methadone, along with counseling and behavioral health, has the gold standard of treatment of heroin addiction, particularly since the 1970s. Several reasons for this. Number one, those patients are much more likely to adhere to their prenatal care as well as their treatment program. It prevents them from going through withdrawal symptoms and reduces the risk of obstetric complications. So the website on there, and that's again, at the end of this slides, I do have a whole list of resources. And so some of these that you see within the slides can also be found at the end. But that's a list of local treatment areas. In South Dakota, what I found really was the Sioux Falls Treatment Center. I'm not very familiar with that particular program. Some of you may. Methadone is dispensed on a daily basis by a registered opioid treatment program. Methadone does have significant pharmacokinetic interactions with medications, especially antiretrovirals, and it can prolong QT in a dependent fashion. It often requires dose adjustments, particularly in the third trimester. And this is just pharmacokinetic and physiologic changes in pregnancy that the changes in the third trimester. A single daily dose may not control withdrawal symptoms over a 24-hour period, and rapid metabolism often develops in pregnancy. And so in these cases, along with potentially having to increase the methadone dose, patients often benefit from split dosing, twice daily instead of once daily. In pregnancy, the methadone should be titrated until the patient is asymptomatic. And the reason for that is that inadequate dosing can result in withdrawal signs and symptoms, which can cause fetal stress. And additionally, of course, the patient is much more likely to relapse and be non-compliant with her treatment and potentially turn to illicit sources for to relieve her dependence. Neonatal abstinence. Interestingly, the incidence and duration of neonatal abstinence doesn't really seem to differ based on the dosage. So there really is no benefit to decreasing methadone dose during pregnancy. There are some studies that find lower rates of neonatal abstinence when that split dosing regimen is used. Buprenorphine is a partial agonist. Again, you're all familiar with this. Buprenorphine can be used in patients who are reliable They can really self-administer their medication and can be trusted to stick with the treatment program. That's listed there as the website for finding a registered prescriber. I believe there are certainly other registered or other prescribers who have decided not to be listed on the website. Let's see. There are a few. Unfortunately, I have not done that training yet, but I believe there are some in probably both of the major hospital systems. And again, may not be listed, so it's not unreasonable to call an OB clinic directly if you're looking for an OB provider who does this. But the other thing, too, is not so much that they have to be an OB provider. They simply need to be a buprenorphine registered provider. You still manage their OB care in conjunction with that provider. They recently approved a long-acting implant. There's no safe data on this, on pregnancy at this time in this, so it's not recommended at the moment, although I'm optimistic that we'll find that this is a reasonable option for pregnancy. So look for that to be coming down in the future. The buprenorphine naloxone combination, Suboxone, I think is the most common for that. Naloxone is not orally active, so it comes in a pill, she swallows it, it doesn't affect her one way or the other. However, if it's injected, then it can cause severe withdrawal, and the purpose of it is to reduce the diversion of the drug. So far, it's not been recommended in pregnancy because of the concern for neonatal withdrawal, fetal and neonatal withdrawal. However, recent studies have shown no adverse effects in pregnancy, so there's a potential, again, that this may be used in the future. So what do you choose? Obviously, methadone is great for your, close supervision for a patient who you may not think is quite as reliable, less risk of diversion. It has some significant drug reactions. It requires dose adjustments, and you have to be willing to make those dose adjustments, and then it requires daily visits, which can be a burden on a patient, particularly if she has a job and others to care for. Butane overdose is less likely, which is good. It does have few drug interactions, and it does not require daily visits, which is beneficial for patients who can be trusted to be responsible with it. There is less need for dose adjustments with buprenorphine, and neonatal abstinence syndrome seems to be less severe with this one. The reports of hepatic dysfunction and lack of long-term data on infant and child effects, as was the case with almost any relatively new drug, and an increased risk of diversion with buprenorphine. Two, if you have a pregnant woman who's on methadone, keep her on methadone. Do not switch her. There is a risk of precipitated withdrawal and going from the full agonist to the partial agonist therapy. So if you're doing well on methadone, just keep her on it. It is okay to transition from buprenorphine to methadone. So if for some reason she's not tolerating the buprenorphine, or you've decided she's really not reliable to continue to take buprenorphine, then you can transition her to methadone. If you have a patient on buprenorphine, or you are thinking about starting a patient on buprenorphine, it is important that you just let her know that we don't have a lot of long-term data on this in pregnancy. We don't think there's a lot of risk, but truth be told, we don't know, as is the case in pregnancy. And if it's an unacceptable risk to her, then she should go to methadone. Supervised withdrawal. The big thing with this is relapse rates are terrible, anywhere from 60 to 90%. And of course, if she relapses, now she's at a higher risk of communicable diseases, accidental overdose due to loss of tolerance, obstetrical complications, and often those patients drop out of prenatal care. Medically supervised withdrawal sometimes requires a prolonged inpatient relationship with intense outpatient behavioral therapy. Early reports raised concern of increased risk of fetal stress and fetal death due to essential fetal withdrawal. More recent studies show that's not a real significant risk. However, and we don't have a lot of long-term follow-up, and it's particularly hard to follow up on patients who have relapsed because they tend to be lost to follow-up. So naloxone, it's kind of mean of me to put these on the same slide because for me it's always easy to mix them up. I feel like somehow the easiest way to keep them straight is just to talk about them together. So naltrexone is a non-selective opioid receptor antagonist, and it's basically meant to prevents from being high from the opioids. It blocks the euphoric effects. There is a long-acting injectable form that's more effective than the oral form. However, research in pregnancy is lacking, which is, again, just the thing with pregnancy. So whether to continue it in pregnancy in a woman who's already taking it involves a careful discussion on lack of safety data versus her risk of relapse. If she's at significant risk of relapse, if she discontinues the naltrexone, I would certainly, in conjunction with a healthy conversation with her, be open to her continuing that medication. Now, as you all know, short-acting opioid antagonist, and this can be life-saving in the event of an overdose. Withdrawal from opioids may contribute to fetal distress, but of course, if a pregnant woman appears to be overdosing, by all means, give her the naloxone. If she's then we can't save the fetus. States, including South Dakota, do authorize prescribing naloxone to a third party, such as a family member or caregiver who might be able to help in the event of an overdose. So, opioid use disorder. Obviously, mental health conditions, depression, anxiety, trauma, post-traumatic stress disorder, and use of other substances, alcohol, tobacco, marijuana, cocaine, methamphetamine. And so all of these things, of course, happen in pregnancy also, and then make the pregnancy even higher risk than it already was. Poor nutrition is associated, which can also put pregnancy at risk, and increase risk of communicable diseases. Support systems tend to be absent or disrupted or extremely dysfunctional, and so definitely be looking at referral for multidisciplinary care, behavioral health, social work, etc. as you need to. This is a heavy topic, so here's a picture of a funny cat to give you a breather. I felt like I needed a breather when I was putting it together. I'll start talking about care. Antepartum care. In the beginning, we already talked about screening. Screen every patient at the very first appointment, universally. Test for STDs and other infectious agents. You already test for gonorrhea, chlamydia, HIV, hepatitis B in pregnancy, and syphilis, but consider adding hepatitis C and tuberculosis. And if you do feel that your patient is high risk, consider repeat testing in the third trimester. I have a positive chlamydia or gonorrhea early in pregnancy. I bring them back for their planned test of cure, and then I always repeat again in the third trimester. For depression and other mental health conditions, I missed hepatitis B vaccine. That is recommended for pregnant patients who are surface antigen negative but at risk for infection. So do consider that in these patients. Consultations as indicated, and this is certainly not an all-encompassing list, but some things you may want to think about: management and or anesthesia, pediatrics, of course, maternal fetal medicine, behavioral health, and then, of course, nutrition and social services. Talking about breastfeeding early in pregnancy and start preparing mom to breastfeed. It should be encouraged in women who are stable on opioid agonists, provided they are not using illicit drugs and they have no other contraindications such as HIV. And talk a little bit more about why breastfeeding is actually beneficial in this population and in their babies. Communication between the OB provider and the pediatric team is key, of course. Your pediatric team needs to be well informed and on board. If you think a neonatologist is necessary, by all means consult them prior to delivery. Substance use, especially tobacco and alcohol, and offer cessation services for those. And then throughout your antenatal care, your care as the obstetrical provider should be coordinated with the addiction medicine provider. And there is very specific consent for release of information to allow communication relating to opioid use disorder. So in labor, it is so important to continue the maintenance dose of their methadone and buprenorphine in labor and postpartum, and tell them you will continue that. Tell them you will continue their dose and that you will manage their pain. So much, I guess, trouble avoided by alleviating patient anxiety and just communicating well. And additional pain relief as needed. You know, these women are going to need higher doses because they'll have significant tolerance. Epidural spinal anesthesia is ideal. You should avoid opioid agonist antagonist drugs such as butorphanol, nalbuphine, and pentazocine, because these can cause withdrawal. And nalbuphine or NuBane has been used a lot in labor, and in fact, I was always trained to use it. I don't use it anymore. My preferred intra-aortic medication is fentanyl. IV due to the short action and the fact that it's not an doesn't agonist-antagonist effect. Keep in mind that not all patients disclose their opioid use. So you could precipitate withdrawal in a patient that you had no idea was taking opioids. And of course, if your patient's already on methadone, you should not give her buprenorphine. Notify the pediatric staff of any infants that are exposed to opioids to ensure that they are properly screened for neonatal abstinence syndrome. Again, consider anesthesia consult for pain management, and then use your multimodal pain approach as you always would. I tend in these patients to make Tylenol and NSAIDs scheduled, and then I'm particularly partial to Toradol if I can use it, and then do the opioids on top of it as I need to. For postpartum care, of course, continue your opioid agonist therapy. If the methadone dose was increased, you really don't need to drop it. And in fact, the guidelines state that reduction should really be titrated to signs and symptoms of sedation, paying particular attention to that peak dosing of about 2 to 6 hours. So, you know, don't feel like you need to just drop her dose right away. Go slowly sit down if you feel like she's showing some somnolence on that particular dose. Buprenorphine patients, they usually don't require a dose adjustment in pregnancy, so they really shouldn't require any postpartum. It tends to be just a little bit easier to manage. Obviously, very careful with other sedating medications, especially benzodiazepines, Ambien, and then antihistamines. The postpartum is a period of increased vulnerability. There are much higher rates of relapse, and potential relapse triggers include loss of insurance and access to treatment. In South Dakota, our Medicaid patients lose their insurance at 6 weeks postpartum, which is pretty quick when you think about it. The demands, of course, of caring for a new infant, sleep deprivation, and then any threat of loss of child custody. So substance use and overdose are increasingly found to be a major contributing factor to maternal mortality in this country. You want to screen for postpartum depression and offer treatment, and then provide adequate access to psychosocial support, including treatment, relapse prevention programs, whatever you feel that your patient needs to continue to be successful and stable on her therapy. Provide patients with overdose training, probably with co-prescription of naloxone, and if you can involve a family member or caregiver in that, the better. As the American College of OBGYN is starting to encourage postpartum care to be considered the 4th trimester, and encouraging us to see our patients a little bit sooner postpartum and show them a little bit more support, and hopefully we'll catch some of these potentially relapsing issues before they become a major problem. Unintended pregnancy rates among women with substance use disorders is approximately 2%. Population is right around 50%, so this is a significant risk in patients who, unless they really want to be, should probably not be pregnant. So during your prenatal care, start talking about the full range of contraceptive options, and in particular, if you feel the patient fit, and especially for patients who may not be very reliable in coming back for their postpartum care, consider immediate postpartum long-acting reversible contraception. It's effective, it's very convenient, she's right there. You can place an IUD immediately after delivering the placenta. You can obviously place an Nexplanon right away. Not is contraindicated in breastfeeding, and Medicaid does cover both, as do most insurances. So this is a really great option to just give that woman some time to recover and to develop a relationship with her baby before she has an accidental next pregnancy. It's beneficial to both mothers and babies in women on methadone or buprenorphine therapy. The great thing about breastfeeding is it actually seems to decrease the severity of neonatal abstinence. Babies have shorter hospital stays, lower costs of hospital stay. It improves attachment between mother and baby. It provides immunity to the infant. And as mentioned earlier, it really should be encouraged in any woman who doesn't have a contraindication and who is not using illicit drugs. If you do, if your patient does choose to breastfeed, it's very important that you tell her if she has a relapse that she needs to stop breastfeeding. So if she, especially if she's going off using illicit drugs, using hair, anything like that, using her methadone and buprenorphine, but using other drugs, needs to stop breastfeeding. The American Academy of Pediatrics recommends breastfeeding for women on methadone or buprenorphine regardless of the maternal dose. Transfer to breast milk is actually minimal for these drugs. As a note, the FDA did recently state that breastfeeding is not recommended while using medications containing codeine or tramadol. They really discouraged it for oxycodone and hydrocodone as well. And the reason is that there's a rapid conversion of codeine to morphine, which can cause high levels of morphine in blood and in the breast milk. If patients on, certainly historically we've always used Percocet as our pain management of choice after delivery. Really stop that. We actually use Dilaudid now because it doesn't have the ultra rapid conversion. If you feel your patient needs a codeine-containing medication, you want to discuss the risks and benefits and counsel her, and then she will need to make a decision as to the safety of that decision, that continuance. That right there is the FDA warning relating to those drugs. Oh, neonatal abstinence syndrome. This drug withdrawal that can result from chronic maternal opioid use in pregnancy. It is expected and it is treatable, and seen in 30 to 80% of women taking opioid agonists. It is characterized by GI, autonomic, and central nervous system disturbances. And so what we're going to see in the baby is irritability, a high-pitched cry, poor sleep, and then poor feeding, which is usually due to just difficulty with sucking reflexes. And is worsened by additional exposures, including nicotine, SSRIs, and benzodiazepines. Caveat to this whole discussion that I am not a pediatrician, but this is information comes from the American Academy of Pediatrics. The methadone neonatal abstinence can occur anytime in the first 2 weeks of life, but most often in the first 72 hours, and it can last several days to weeks. Buprenorphine, not as severe. This one appears in 12 to 24 hours, and then peaks at about 72 to 96 hours, and it resolves by 7 days. Neonatal abstinence outcomes are improved with validated screening. One most commonly used to my knowledge is the Finnegan scale. But should develop an evidence-based written policy to assess and treat neonatal abstinence. Again, communication is key. Explain to families and to mothers what that policy involves, what the key components are, so they know what to expect. And they'll be a lot less anxious about what's happening. Decreases the duration and severity of neonatal abstinence. It should be encouraged, and you should be encouraged to visit and care for their infants. So a couple of resources there for optimizing collaboration, diagnosis, and treatment on neonatal abstinence. And there's some good information at that. That first website does include the Finnegan scale. Slide, and I'm going to try not to belabor it too much, but this is an evidence-based approach to neonatal abstinence as outlined by the American Academy of Pediatrics. It's not necessary for every infant, and I know it's hard for us sometimes to accept that our intervention is sometimes worse than no intervention. And this may be the situation for some of these babies. So neonates with known or expected exposure should be monitored. Environment should be kept low stimulus, and they should be watched for up to a week, depending on the type of and timing of use. Infants with mild to moderate symptoms should really not be treated with opioid replacement. The Finnegan scale will identify the appropriate treatment course for these infants. Subject therapy should be the first-line intervention. They should be coming in with their mother rather than placed in the NICU whenever possible. Comfort care is very important. Skin-to-skin contact is terrific for these babies, and of course all babies love to be swaddled, and these babies are no different. Minimizing environmental stimuli, promoting rest and sleep, and providing sufficient calories with breast milk and supplementation as needed. Encourage breastfeeding regardless of current opioid use if there are no other contraindications. Neonates requiring greater intervention as determined by the Finnegan scale used with an opioid. Long-term infant outcomes, obviously don't have any randomized controlled trials here, but there are several observational studies. The challenges of these studies is the founding factors. So many of these women are using other substances, including tobacco, alcohol, and non-medical drugs. They often have exposed to other risk factors. Their low socioeconomic status, or poor prenatal care. But despite all of this, in groups for age, race, and socioeconomic status, there's no difference in cognitive development between children up to age 5 exposed to methadone in utero and those that were not. However, because of the confounding factors, these groups were often lower in both compared with population data. Interventions that focus on supporting moms and other caregivers, early childhood development, enrichment, and improving the quality of the home life are certainly most likely to be beneficial. So issues. This group that we as physicians really need to advocate for. We improve availability of treatment because right now it is a problem. We really don't want patients to be criminalized for seeking care. All the major organizations out there have said that the problem of drug and alcohol abuse in pregnancy is best addressed with education, prevention, and community-based treatment, and not through punitive drug laws and criminal prosecution, because outcomes actually tend to be worse in those cases. Research that whether or not a woman can stop her drug use, obtaining prenatal care, staying connected to her system, and being able to speak openly with a physician about her drug problem helps to improve birth outcomes. That website down there is just a link to an overall the Geiger Institute on state policies regarding exposure in pregnancy. Interestingly, often well-intentioned but uninformed as to the evidence, supporting healthy outcomes for both moms and babies. And what I've in this particular situation is the now debunked crack baby rhetoric that arose in the 1980s, which resulted in stigmatization of women addicted to crack. Even alcohol and tobacco use are actually more detrimental to a fetus. We know that crack and cocaine can increase risk of placental abruption and preterm birth, but overall long-term development of children is far more negatively affected by tobacco and alcohol use in pregnancies than by those substances. The result of this was overly coercive criminal and punitive measures that actually impeded the care of women and children. And to the overwhelming scientific consensus based on over 20 years of child development research has not identified a recognizable long-term condition, syndrome, or disorder that should be termed crack baby. So it's not good that poverty, poor nutrition, and inadequate health care can account for any of these effects have been falsely attributed to crack or cocaine. And in many ways, there are some similarities to be drawn between that and I'm not downplaying neonatal abstinence at all, but I'm saying to give these women and these families support and encourage their access to health care rather than driving them from it out of fear. South Dakota, substance abuse during pregnancy is considered child abuse and grounds for civil commitment. South Dakota law states that the term abused or neglected child includes any child who is subjected to prenatal exposure to abusive use of alcohol, marijuana, or any controlled drug or substance not lawfully prescribed by a practitioner. Consent is required for a urine drug screen in South Dakota, and the law, which you can be happy to send it if anybody's interested in the actual terminology, allows for newborn toxicology without parental consent if they have reason to believe, based on medical evaluation or the mother or infant, that the mother used a controlled substance for medical purpose during pregnancy. Those results must then be reported. So it's, again, certainly we should test women and infants as we feel is necessary, but it's all very important that we communicate the ramifications of testing, particularly in women and urine drug screening required. This is kind of a nice little table on data on things that tend to help moms and babies have good outcomes versus things that don't. And the column there is things that tend to result in poorer outcomes. So overtreatment of neonatal abstinence with babies in the NICU tends to result in longer stays and higher costs without improved. Criminal penalties for women and doctors, mandatory urine testing actually does not seem to be helpful. Mandatory reporting to Child Protective Services. Keep in mind that a woman who has used an opioid isn't necessarily a child abuser. Now, certainly there are situations in which if you do suspect abuse, yes, absolutely it needs to be reported, but there's a slippery slope there that needs to be kept in mind. Over-reliance on fragmented prescription drug monitoring programs. I do think that is improving. It's improving a lot in South Dakota and our surrounding states. Drug treatment course, forced withdrawal, and anti-family one-size-fits-all drug treatment programs. We'll talk about that a little bit here soon. And, of course, losing sight of the real harms of alcohol and cigarette use, which we talked about a little bit earlier. So things that help. Appropriate comfort care, low stimuli environment for babies with neonatal abstinence, public health approaches on focusing on prevention and treatment, essentially just, support for these women and their families, adequate screening and universal screening, statistical reporting to CPS for any actual indications of impaired parenting as opposed to just based on lab. Family-centered drug treatment programs are huge, and unfortunately there really are not enough in this country, and that's something we need to improve. Opioid agonist therapy, much higher rate positive outcomes when compared to withdrawal. Again, family-centered, community-based on treatment, and then counseling on family planning and contraception when indicated, and then continued focus on alcohol and tobacco, which provide significant threats to pregnancy. Which I just went to, access to treatment. Most treatment programs are not tailored to pregnant or parenting women. A few that are rarely provide child care. They often don't account for the woman's family responsibilities, and they don't provide treatment that she can afford. Very few programs give priority access to pregnant women. And in the course of treatment, a woman should not be separated from her family. Substance abuse treatment that supports the family as a unit has been proved to be far more effective for maintaining maternal sobriety, child well-being. Therapeutic opioid maintenance treatment, their physicians should not be pressured to detox by court-ordered treatment programs. And I will give, I really had a hard time finding anything locally where a woman could have inpatient treatment with her family. I did finally find a place with the assistance of a partner of mine, and I'll share that with you at the end. But there's some really good data showing that mother can bring her child or children with her to treatment. If there's a way to treat them as a family unit, the outcomes are just much, much better. So I'll talk a little bit about other substances. I don't even know how I'm doing on time. I'm getting a little over, so I'll have to stop here pretty soon. But the greatest preventable threats, and curbing the use of that is going to improve our public health gains much more than almost any other intervention. Tobacco alcohol dependence may independently cause neonatal abstinence, but the symptoms may be more subtle than with opioids. And decades of evidence have shown that alcohol and cigarettes cause long-term serious health consequences for moms and babies, including prematurity, and smoking is still the #1 risk factor for delivering a baby prematurely. Substance use is very common, so if you have a patient who's misusing prescription meds or taking illegal meds, are also most likely smoking or using alcohol. And the adverse effects that are being caused by the alcohol and tobacco may be misattributed to illicit substances. Fetal alcohol syndrome is the most common preventable cause of mental retardation. As you all know, there's no safe level of alcohol consumption in pregnancy. It does cross the placenta. About 10% of women use alcohol in pregnancy, and about 5% report binge drinking, so it continues to be a problem. It's important to us to intervene early in pregnancy. About 10% of women smoke. Of those who quit, about 40% will restart postpartum. 50 to 60% will restart postpartum, but 40% will quit in pregnancy and relapse. So it's really important throughout the pregnancy, and then especially in the third trimester, that you make a plan for helping the patient prevent a relapse here. You guys know the risks of smoking in pregnancy, and I'm a little bit ahead of time or running over time, so I'm not going to go through all of these. Obviously, a major, major problem in pregnancy, and sometimes something we lose sight of. In pregnancy, I do want to say about this because we're seeing more and more of it. It is the most commonly used illicit drug in pregnancy in states where it's considered illicit, but growing numbers of states are legalizing it. However, there are concerns about impaired fetal neurodevelopment. And of course, it's often smoked, can have other negative effects on mother and baby. OB providers should not suggest or prescribe marijuana for medicinal purposes during preconception, pregnancy, and lactation. And women who are pregnant, who are considering pregnancy, should be encouraged to discontinue their use of marijuana. And if they're using it medicinally, consider alternative therapies. And then marijuana should be discouraged during lactation because we just have no idea what effects it might be having on the baby. As pregnancy, I am seeing a lot of this, I'm sure most of you are too, has continued to increase in the U.S. since the 1980s. Obviously, it does endanger maternal health and significantly increases risk of low birth weight, small gestational age, also placental eruption, and development problems in pregnancy. A urine screen may detect meth, but it should be done with consent after counseling regarding ramifications of a positive result, as with anything. And then who do report continued use of meth should be referred for treatment and for follow-up of serial ultrasound to assess fetal growth. Again, it's always important to develop that rapport with your patient that she can trust you and can be open with you so that you can adequately treat her issues. So, universal screening, intervention, and referral improve maternal and infant outcomes for opioid use disorders. Contraceptive counseling and access is a routine part of substance use treatment in both a non-pregnant and pregnant patient. Pregnancy should be co-managed by the obstetrical provider, whether that's an obstetrician or family practitioner, and addiction specialist. Consider modifying care as appropriate, including expanded infectious disease screening, additional growth ultrasounds, and consultations with other providers. Opioid agonist is strongly preferred to medically supervised withdrawal in pregnancy. Infants should be monitored for signs and symptoms of neonatal abstinence, and then multidisciplinary long-term follow-up should include medical, developmental, and social support to both mother and baby. Sanctions in pregnancy reduce access and compliance with care and are associated with poor maternal and infant outcomes. And obstetrical providers have an ethical responsibility to their pregnant patients with regard to substance use disorder. They discourage the separation of parents from children solely based on substance use disorder, suspected or confirmed. So the next few slides are resources, and I think I can really share those with Mark that you guys can have access to them if you like. That first one is an ACOG site, accessible to everyone. You don't have to be an ACOG member to get to that page, and it contains a million links to a bunch of other resources. A million, a little bit of hyperbole, but it's really a terrific site. So I would encourage you to look at that one. The next couple of bullets are screening tools. So feel free to choose one of those that you feel would be effective in your practice. State laws, there's the Guttmacher website, and then some of the areas to find local treatment programs and buprenorphine prescriptions, comes to naloxone prescriptions and laws related to that. And then abstinence syndrome, consent for communication between an addiction specialist and an OB provider. And then this was the one inpatient recovery program that I could find that is friendly. I don't know a lot about it personally, but this is kind of, from everything I read on it, this seems to be the idea of what ACOG is really trying to support. It's called the Jackson Recovery Women and Children Center, located in Sioux City, Iowa, and that's the contact information there. And that's the end. And I'm happy to take any questions if we can figure out how to.
Sure. And we're coming right up on our time, Dr. Schipper. I'll go ahead and open the phone lines up. If you have just a minute, we'll see if there's any questions. But if not, would it be okay to have people who participated in this or listen to this after the fact send me questions and I in turn send those to you?
Fine. And I actually, my email's right there on that last slide. They can certainly email me directly if they prefer.
Perfect. No, that's okay. We got off to a late start and very good information. So let's open the phone lines here quick. Any questions for Dr. Schipper? And I apologize. I will try to keep us right to our hour. So Dr. Schipper will certainly, any questions that come in, I'll forward to you. You do have your contact information there, so that is great. I want to close by thanking you very much for doing this presentation. I think a lot of excellent information is presented to us today. I do thank you enough. I think it's been a very informative series, and this is one area that we certainly need to cover. As we close it, I want to remind everybody that this session will be recorded. We'll post it online, so if you wish to listen to it again or share with a friend, I'll make those links available. With that, I need two more things to remind you of. One, we have a number of resources on the SDSMA website, and so all of those are available for your viewing. Then at www.sdsma.org. And I also want to remind you that we have two more programs in the series, one on safe and effective tapering of opioid medications and on MAT. And so with that, I thank everybody for joining us today, and I wish you a good evening.
Thank you.